Today we are going to present a case of neuromyotonia. Dr. Ganga will be presenting. She's our first year PG. She's a first year PG, and this case, I thought I will present because it's more. It's not about any diagnostic challenge or something. It's more due to its novelty. So it's very rare that internal physician will come across a case like this, and I am really lucky that I came across such a case. And when we look at the literature, these cases are very few. So very few described, and it to come to general medicine. Okay, so most of these cases would have gone to neurology, but somehow it ended up with me, and I was happy that we could make a diagnosis and treat the patient. So for the rest of the things, Dr. Ganga will be presenting the case, and she will take you through the case. Over to Dr. Ganga.
Good evening to all the esteemed doctors present here. It's my honor to present a case here at IMA House. I'm Dr. Ganga Thulasi, DNB resident, internal medicine in Medical Trust Hospital. A 42-year-old male patient presented to our OPD with abnormal involuntary spasms, myokymia of mainly the calf muscles, occasionally the muscles of the upper limb and face since 3 weeks. He also complained of constipation since 10 days, excessive sweating since a week, urinary retention since a day. He also observed difficulty in standing and walking, weight loss, decreased appetite, history of alteration in behavior and nocturnal confusion, history of facial, temporal, jaw muscle stiffness and dryness of mouth. History of arthritis-like symptoms with recurrent exacerbation, for which he was on Ayush medications 2 months ago. On examination, was conscious oriented. BP was on a higher range, 190-110 mmHg. Other than that, general examination was normal. On systemic examination, CNS higher mental functions were normal. Power was normal in all 4 limbs. Myokymia was present in the bilateral lower limbs. Plantar reflex was bilateral flexor. Deep tendon reflexes showed hyporeflexia. This was at the time of presentation. Investigations at the time of admission revealed the CRP was raised, mildly raised actually, 10.3. The creatine phosphokinase was 5207. Calcium and magnesium was mildly decreased, 8.3 calcium and magnesium of 1.5. The liver enzymes, SGOT was 180, SGPT was 115. Sodium was markedly decreased, it was 100 millimoles per liter, and potassium was 3 millimoles per liter. The line of management that we went through were, in view of persistent elevated blood pressure readings, he was started on antihypertensives. Bladder was catheterized and clear urine was drained. Toxicology panel was sent to rule out heavy metal poisoning from Ayush medications. Oral potassium correction was started. Hyponatremia correction was gradually initiated. Hyponatremia evaluation was done, which showed urine sodium of 70 milliequivalents per liter, which was raised. ATM cortisol of 20.21 microgram per DL, which was elevated. Serum cortisol decreased to 36 milliosmoles per kg. Urine osmolality was 256 milliosmoles per kg. Features were suggestive of SIADH. On 2/6/2022, after the correction was started, sodium was 107, potassium was 3. USG abdomen and pelvis showed normal study. Neuromedicine opinion was taken, and in view of slow progression, history of arthritis symptoms, recurrent exacerbation, and other supporting history, along with an increased CPK, CRP, SGOT, SGPT, and markedly decreased sodium, an inflammatory disorder with peripheral nerve hyperexcitability was considered. Autoimmune workup, including ANA profile, antibodies against voltage-gated potassium channels, that is antibodies to LG1 and Caspar-2, were sent to consider neuromyotonia or ISEC syndrome on 1st June 2022. NCV done showed conduction abnormalities which are suggestive of neuropathy. EMG showed fibrillation, fasciculation, duplets, polypets, suggestive of neuromyotonia. On 4th of June, his sodium was 120, potassium was 3.2. To rule out the central causes of SIADH, an MRI brain was done, which was normal. To rule out the paraneoplastic cause of SIADH and myokymia, CECT thorax was done, which showed ill-defined areas of ground glass opacities in the right upper lobe and lower lobe, which was suggestive of an infective etiology. Tuberculosis workup was done, which was negative. Sputum, Gram-Stein and culture were sent, after which he was started on IV cephalosporin sulbactam in view of rising counts, which was about the TC on 6th of June was 18,000. The culture sensitivity reports showed normal flora. On 6th of June 2022, the toxicology panel came out to be negative. Peripheral smear done showed neutrophilic leukocytosis. CECT abdomen and pelvis was done, and the provisional report showed sigmoid colon thickening. Hence, a colonoscopy was done on 8th of June, and normal mucosal study was seen. Biopsy was taken from ileum, right colon and left colon, and it showed no diagnostic pathology. On 8th of June, the VGKC, that's voltage gated potassium channel antibodies, LG1 and Casper2 came out to be positive. Since all the possibilities of neoplastic etiology of SIADH and myokymia were ruled out, diagnosis of autoimmune ISAC syndrome was made. Neurology review was taken and he was advised IVIG or plasmapheresis. Plasmapheresis was started on alternate days with 2.5 liter fluid removal and replacement with 7 FFPs. This is the report with antibody to LGI1 and Casper2 being positive. The first plasmapheresis was done on 10/6/2022, and the sodium on that day was 120, potassium was 3.9. On 11th, the sodium was 128, potassium 4.7. On 12th of June, second plasmapheresis was done, and sodium was 136, potassium 4.2. A total of 5 sessions were carried out, and the fifth session was completed on 18th of June 2022. By the third plasmapheresis, his symptoms, myokymia, showed significant improvement. On 18th of June, his CRP fell to 1.8. Total count was 11,000, hemoglobin of 14.6, and platelet of 3.1 lakh. Urology consultation was sought for difficulty in initiating micturition, and he was started on alpha-adrenergic antagonist. Myokymia, urinary issues improved. Sleep, appetite, general condition got significantly better. He was started on IV methylprednisolone on 18/6/2022 for 3 days and was discharged with oral steroids. After 3 plasmapheresis sessions, this was the result. You can see the myokymia significantly decreased. At the time of discharge, on follow-up, he was asymptomatic. Mycophenolate mofetil was added, 1 gram daily, and steroids were tapered. Presently, over the course of 6 months, he is on mycophenolate mofetil, 500 mg per day, and is asymptomatic. About the neuromyotonia, it presents ISAC syndrome. It presents with painful muscle cramps and stiffness, slow muscle relaxation after contraction. It affects most commonly adolescents and young adults. The characteristic features include fasciculations, myokimic and neuromyotonic discharges on EMG, reflecting motor nerve hyperactivity driven by abnormal peripheral firing. Due to the excessive muscle fiber activities, the patients with ISAC syndrome will present with weight loss, muscle hypertrophy, and hyperhidrosis. Association with thymoma is also seen. The pathogenesis is actually an autoimmune target is the voltage-gated potassium channels found along the peripheral motor axons, and it's responsible for repolarization after action potential firing. It results in reduced potassium efflux from axons and nerve terminals, and it leads to higher membrane potentials, inappropriate action potential firing, and acetylcholine release. When the autonomic nerves are affected, excess sweating, salivation, and lacrimation are observed. The VGKC antibodies can also cause Morven syndrome, which encompasses all the clinical features of acquired myotonia with a fluctuating delirium. Effectiveness of plasma exchange supports the role of autoantibodies. The Caspr2 antibodies is a protein important for the clustering of voltage-gated potassium channels in juxtaparanodal regions of both peripheral and the CNS axons. Other associated antibodies are often paraneoplastic. The ones are NACHR, CRMP5, amphiphysin, antinuclear neuronal type 4. The differential diagnosis of Isaac syndrome include limbic encephalitis, Stiffman syndrome, rippling muscle syndrome, Schwartz-Jampel syndrome. The treatment modalities, no specific treatment has been recommended in view of low number of reported cases. Various treatment modalities are used by different authors, like anticonvulsants like carbamazepine and phenytoin, immunomodulatory treatment with IVIG, plasmapheresis, and steroids, sparing agents like azathioprine, methotrexate, and mycophenolate mofetil. The largest case series of 20 cases were reported from Jaipur SMS College, Department of Neurology, and the salient features of this case series include presence of undulating movements predominantly in the calves in all the patients. Other symptoms with varying frequency include muscle stiffness, pain, insomnia, irritability, tachycardia, and excessive sweating. Surprisingly, 50% of patients had recent history of treatment with alternative system of medicine. Investigation revealed myochemic neuromyotonic discharges on the EMG, positive antibodies to the voltage-gated potassium channels, LGI1 and Caspr2 were seen. The treatment response to IVIG and methylprednisolone were seen. All 20 cases in the series were also found to have an autoimmune etiology. So this was about the case. Thank you.
Thank you for the great presentation, Dr. Ganga. So any questions from the audience?
From Madhya Pradesh, Delhi side.
Okay.
After Covishield vaccination, one patient developed this syndrome.
Okay, fine. Yeah, actually this patient had this doubt also because he had received his Covishield some 2 months before he. Maybe I should look back into that factor also. But other striking factor was, as the case series told us, out of the 20 people in Jaipur, when they found they have neuromyotonia, 50% of them had used alternative system of medicine. And this person had gone to a Siddha doctor who gave him something for the treatment of arthritis. And he took the treatment for around 3 or 4 days, and after the 5th day he started developing the symptoms. So we still need to find an association, if there is some association between alternate medicine treatment and development of autoantibodies to the voltage-gated potassium channels. Apart from that, the literature is very sparse, so it's all speculations. In US, there is a total of around 1,000 cases which have been reported, and no particular mode of treatment has been found to be superior, and each author has used their own treatment, but the basic crux lies in the fact that immunosuppression and to find for any underlying malignancies. So the complexity is, if there is an underlying malignancy, most likely like thymoma or a small cell carcinoma. The other factor is there is a close differential diagnosis with another syndrome called Morven syndrome. Now, Morven syndrome presents with predominantly central nervous system manifestations like delirium, agitation, hallucinations, lack of sleep. And if you notice, this patient also had few of those symptoms, though they were not as severe. So I discussed with Dr. Radhakrishnan, he is a neurologist, and he has seen a Morven syndrome. So he felt that this will not fall into the classical Morven syndrome, but there might be an overlap. And Morven syndromes are very difficult to treat. But fortunately, our patient recovered very well with the plasmapheresis, and if it is proved to be a Morven syndrome, then it might be one of the few cases of Morven syndromes that we have treated worldwide. Other than that, one unique feature in this patient was the urinary symptoms. So all the case reports which I went through, they didn't have any urinary symptoms, and he had presented with urinary retention. Though the autonomic nerves are involved in myotonia, so we could say that this is one rare case where there is a autonomic nervous involvement involving the bladder. So these are the take-home points I will say which I can get from this case. However, I think this case is quite rare, and I hope I can see one more case like this in my lifetime.